Hello, my name is Eric Hill and I'm your medical director. Today we're going to be discussing video laryngoscopy. A few months ago we introduced a new device and a new skill set to our armamentarium to treat patients, and that is the Air Traq video laryngoscope device. The reason we're going to be discussing this is a different technique than what we've traditionally done. Traditionally, paramedics have been trained to do direct laryngoscopy. There's a few distinct differences as to the way you intubate somebody with a video laryngoscope. The Air Traq device is very successful, and it has a hyperacute angulated blade, which is very similar to what we use in the emergency departments to intubate patients. However, it requires some different skill techniques. A lot of practice is needed and watching videos in order to understand the anatomy that you're seeing and to be able to be more successful with our intubations. Our intubations, our goal is to always get them on the first pass, okay? And everything you can do to optimize your chances of getting them on the first pass will increase your chance of getting it. We only allow 2 attempts in our system, okay? So if you cannot intubate on 2 attempts, you need to be reverting to your rescue airway device. Okay. So the first step in any airway is to manage it with basic life support maneuvers. There's a reason why we put ALS airway management in cardiac arrests a little bit further into the resuscitation effort, and it's because the ALS airway management, it by itself does not necessarily lend to a better outcome for the patient. And if I can manage the airway through basic maneuvers initially, there is no rush for me to jump right to an intubation, okay? So EMTs, if you have a crew of 4, crew of 5, right off the bat, if you're the lead paramedic, you should be delegating someone for like a chest compressions and then some people on the airway. That gives you several minutes to get everything else set up, get the cardiac monitor in place, defib pads, start an IO, give your first round of medications, etc. First step is to do passive oxygenation, okay? So we're gonna be doing 15 liters a minute via nasal cannula. Once you put that on there and start sucking out the airway, you can get a lot of oxygen flowing into that airway. It washes out all that nitrogen out of the dead airspace, so you have a hyper-oxygenated, saturated airway. So even with just chest compressions alone and a hyper-oxygenated airway, you are extracting oxygen into the tissues, even without doing bag valve mask ventilation. Once we have the nasal cannula in place, I would suck out the airway, have your suction in place, and have them suck out as much of that fluid out of there because we want a good pathway for that air to get down to the airway. So we suction it out and go ahead and place an oropharyngeal airway. So once I've placed an oropharyngeal airway, we can go ahead and place our mask onto the patient and hold it in place. Okay, this allows us to do a couple things. One, if I create a tight seal and if I have end-tidal capnography in place, I can actually get some sampling of what their carbon dioxide output is. 2 is that when I periodically during rescuer changes, you give a couple good breaths in there, but I think it helps open up a little bit of atelectasis that is in the lungs and improve some airflow. But the primary adjunct here is just to do the high flow nasal cannula. While that is happening, you want to know from your people that are managing the airway is, are they getting good compliance? When they're bagging this patient, is it going in easily? Are they getting good airflow, okay? If that is not happening, if you are not able to oxygenate this patient and ventilate this patient adequately through BLS maneuvers, then that might increase the need to do your advanced airway much sooner, okay? But if there's no rush, if you have time, if BLS airway is going fine, you have time. Let them do this for a few cycles while you're getting your stuff together, get your other things in place, get your IO, get your meds, get all your initial things in place, and then you can start getting your airway device in place. Okay. Now that we're ready to do an advanced airway maneuver, we're going to get our laryngoscope set up in place. When you first open your package for your disposable blade, you have to just choose your appropriate size of tube. This one is obviously meant for a little bit smaller adults, 6.0 to 7.5. You can pass a 7.5 in this, but I would recommend that if you're going to be intubating, I would use the blue one for anything 7.5 or bigger, just given ease of passage of the tube. when you first get it out, take off your disposable eyepiece set and turn on your blade. It's normal to see a flickering of the light for up to 10 seconds while the thing is heating up. And that decreases fogging during the intubation process. Next thing we're going to do is take our camera out of our case and plug it into the device. The camera will automatically turn on once it's clicked in place and start recording, okay? It is not meant to turn off the recording feature during the intubation. As you can see, I've got 181 minutes of battery life here, and I can record plenty of video time during the intubation, so we can always go through the intubation process. Don't hit the stop record button during the intubation process or before it at any time. Once I have that in place, I can leave that there. I'll get my tube out. In this case, I've got a 7.0. Okay. It's okay to go ahead and hook on your tube, hook on your syringe onto your tube. I would not do a pilot balloon check, okay? There is always a possibility when you're putting air in and pulling it back out again that you're going to leave a little bit of air in the cuff. One complications we have had is the balloons tearing during the intubation process, and that's primarily, I think, because when you're passing it through, it just tears the balloon. We did get new low-profile tubes, and that has decreased the incidence, but it's still not zero. So don't do any cuff checks with the thing prior to intubation. In 20 years of doing this, I've yet to see a single tube that came out of the package with a tear in ahead of time. It's very important with these tubes that we're going to lube up the track, okay? That can be done either you put it directly into the track this way or directly on the tube itself. But either way, you're going to want to place it in the track there, and that helps to ease in passage. Once I'm here, okay, I only want to place the tube as far down as the tip of my clear plastic. Don't go any further. Some of the videos I've seen of people as they're kind of going this back and forth, stuff like this. Every time you do that, you risk tearing that balloon. And plus, it's right in your middle of your camera view. So leave it there at the very end of your piece. Now that we've done all that, we're ready to go, okay? I got my lube tube in place, my syringe is on the camera. I look at my camera, and before you place it in the mouth, make sure that everything is still in place. Make sure your camera's still in place. Make sure that you're still recording correctly. And if you're not, if you accidentally turned it off for some reason, like that, it does give you a 3-second pause. But if it does, you notice that it's not recording, you'll see that there's no obviously recording light up there. There's no countdown timer. Hit the record button, okay? I want to make sure that we can review these things in real time. Anytime you intubate and you don't have a recording, that requires an atypical report so we can find out why there was no video attached to the tube. But as you can see, at this point, we're ready to go. So once I'm ready to intubate the patient, I have everything in place. Make sure you have your syringe attached to your balloon. Make sure your camera's ready to go. Make sure your recording device is on. Okay, like I say, it should be automatically turned on, but if you happen to turn it off for any reason, make sure that you are recording prior to intubation. When I start getting ready to intubate, the first thing I have to do is I have to suction out that airway. You need to suction it out really well. It is important when you're doing this is that as you suction, get it down in there, suck as much fluid out as you possibly can. If you're putting camera into a bunch of blood and vomit, you're not going to get a good picture. By far, this is the number one problem we're having with our intubations is we're not getting good visualization of cords because of this. Okay, so suction it out. If I'm getting a lot of fluid out, a lot of blood, a lot of vomit, just leave the suction in there. Okay, I can still take this out and still intubate, and I'll demonstrate that in a second with that suction device in there. But if I only get a little bit out, it's okay to suction it out and pull it back out before I intubate. Once I'm ready to intubate, okay, it's important to go midline. Okay, this is not one of those ones where we're going to go on the right side and sweep over to the left like we do with the regular DL. Okay, this is meant to go midline down the normal course of the tongue. I literally just march it back the normal angle of the tongue. And if you look at the blade, the way it's designed to just kind of slip down that path. So if I scissor open the mouth with my fingers like this, little scissor technique, and I go midline, it's designed to go down. And I notice I'm not hubbing it all the way down and pulling back. As I'm going down, I'm marching and seeing what I'm seeing. So here I'm seeing a little bit of tongue. I'm seeing the beginning of the vallecula and the epiglottis right there. So I know I'm close, but not quite there. So I'm going to put it a little bit further. And then I'm going to intubate. So here I got my view. This is being used as a traditional MAC style. I'm in the vallecula, my epiglottis is there up front. I'm a little off to the side a little bit, so I can manipulate it over a little bit more to the middle if I want. But this is still a very good view to be able to intubate. Once I have this view, all I need to do is advance my tube down, and it should march right down through the cords. Like that. Once you have that in place, you disengage your tube off to the side, hold it at the corner of the mouth, and then slide your thing back. Just follow your track back out you did before. Once again, as before, we're going to inflate our balloon and confirm placement using bag valve mask with a capnography device, making sure that I've got a good waveform, making sure that I've got good equal rise and fall of the chest. And then after you do that, you can secure your tube. So now I want to demonstrate for you guys intubating with the suction in place, okay? As I said before, if you put this in there and you get a lot of vomit out and whatnot, leave that in place during your intubation attempt. Just tuck it over in the corner mouth, leave it back there, continue to suck out as you advance your tube. There's plenty of room to leave that suction in place, still open up your airway, and start advancing, okay? You may have to just tuck it over to the side a little bit to get your view. But once again, I got it down in here. As you can see on the monitor, my catheter is down, actually it's pointing right at the esophagus right now, and I'm down here in place, and I'm still getting my view. Okay, I'm a little bit close here, so I'm gonna back it up just a little bit, kind of pull it back out a little bit and just increase my angle, just a little twist. Noticing I'm not using it as a fulcrum, I'm not using a lot of pressure on it still, but I got good cord view there. Nope, not quite. So in this case, I'm just gonna manipulate it just a little bit. There you go. Once again, I'm going to disengage. At this point, you can pull your suction out because the tube's good. And then you'll do your normal confirmation techniques as you normally have done before. Okay. Next thing I want to show you guys is just some simple techniques to improve your image that you're getting during the intubation technique. One common thing I'm finding is that when I'm reviewing these videos is that when we're going down, automatically we're really close. So they get a nice picture, but at this point here, this is where I'm at. And I'm really close to the airway already, and it's very hard to intubate at this level. Because if you remember, your tube is going to come in from the right lower corner here. That's where it normally wants to advance. So if I'm trying to advance from here, okay, this place is kind of bouncing in. But sometimes I'm seeing is it's kind of hitting the arytenoid cartilage right here, and it's bouncing back and forth off of it, okay, and I'm not getting it in. So if I bounce back, pull back just a little bit here, I want to, with the simple manipulation of my hands, I'm just going to pull up a little bit, get it out of my airway. I don't want my view of the cords to fill the entire airway, okay? I want it nice and midline like that, and then I should be able to advance my tube through the cords, just like that. One other thing you can do is, sometimes when they're down here like this, people are having problems kind of hitting, once again, they're hitting that right arytenoid cartilage with the tube. A simple maneuver where I'm just going to tweak my hand to the left a little bit. If you notice, I shifted just a little bit, the view off to the left, I turned my hand to the left and I shifted the camera view off to the right. Now when I do that, my actual tube is actually lined up more at the opening directly, and that makes it for an easier passage of the tube into the airway. One thing I want to mention too is the need to always be maneuvering your blade to get the best field of view of what you're looking for. You need to be looking for what looks like normal anatomy to you. In this case, I'm putting the Airway device in, and I'm not seeing much of anything. I'm seeing black because I've realized I've forgotten to turn back on the disposable blade. So I'm turning that on. That's what you'll see. Sometimes I'm seeing people look like this, and they're kind of off on the side a little bit. They're kind of tucked in the corner of the mouth, and they're not really seeing anything that looks like normal anatomy. And so they're just kind of looking around there, and they're just kind of struggling to find anything that looks normal. They're like this. Well, in this case, if you just kind of pull back, try to go midline to the mouth, you may have to go a little bit deeper, but look around for something that looks normal. Okay, if I'm like down here and I'm seeing this, okay, maybe I'm thinking, well, I'm looking at where I'm at with the blade. I'm pretty deep there. Okay, maybe I need to pull back a little bit. Okay, now I'm starting to see the arytenoid cartilage in place. So now I'm kind of getting closer. Now I can kind of manipulate my blade to get my field of view that I want, and then I get my view. But you should always be kind of looking around. If you're not getting anything that looks normal to help kind of guide your camera to where you want it to be, you're not doing it right. I want to make sure that we optimize our time inside the mouth. All right. So one thing that we're doing is we're intubating during a cardiac arrest. It can be very challenging sometimes to actually pass the tube with active chest compressions because the cords are moving up and down a lot. If you get it down in there though, and you at least get your view in place, you know where you're at, make sure you do that, the 30 seconds before I'm doing a rescuer change. I will place the camera in the mouth, I'll suction it all out, be in place, and be ready to go. So as soon as I have a momentary pause where I can pass the tube, I will. If you're able to pass the tube during active compressions, fine. But if you can't, just maintain your position, maintain your field of view. So as soon as that pause happens, I pass my tube in, pass the cords, and once I disengage that, I'm good to go. And you can literally have no break. We should never, ever be delaying chest compressions to intubate a patient. Our goal should be 5 seconds during the rescuer change. Certainly never, ever more than 10 seconds. The only things that really show survival benefit in our cardiac arrest so far is our compression fractions, our hand time on the chest. So we should be 90% or better. So in any given minute, you should be 90% of the time on the chest. In a 2-minute cycle, we never allow more than a 5 or 10 second pause for rescue or change. Other than that, we're not doing the right things in order to resuscitate our patients. Okay, so we've covered several important things that I want to emphasize in this video. One is just properly setting up your device ahead of time and taking your time during the intubation process. You got to make sure you've got a nice clear airway, suction it out very well, and possibly even leave that suction device in there if you've got a lot of secretions. Even if you have the camera down in there and you're starting to see some more secretions, go ahead and pass the catheter, the suction catheter down the side, suck out your airway to optimize your visualization. Keep in mind that every time your disposable blade passes the teeth, that counts as an attempt. Okay, we only do 2 attempts. Every time we put our blade in the mouth, we're going to cause, risk some tissue damage, some bleeding, makes things harder. We're not there to just continually mess up the airway. And the odds are that if you can't get it in 2 attempts, your odds of actually getting that airway are very, very, very low. So we do 2 attempts before we go to our rescue airway device. Okay, the only time that we should be going any further than that is if the rescue air device cannot work. If I try 2 intubation attempts, if I don't get it, if I put the eye gel in, if I'm able to ventilate this patient, I've got capnography readings, I'm able to ventilate, then leave that eye gel in place until we get to the hospital. We've got a few extra airway adjuncts and some more experience to see if we can get intubation at that time. If you cannot ventilate with an eye gel, okay, then you're concerned more like, do they have some kind of obstruction below the area of the vocal cords? That's about the only time you would ever look for a crike, is if we cannot oxygenate and ventilate through basic maneuvers, supraglottic airway, or through an endotracheal tube. Our goal with intubation is that we should have a 90% first pass success rate. So every attempt, you want to make it your best attempt. You want to optimize the head position, keep it in a nice neutral midline position. As you notice, even with a C-collar in place, if I had one, it's not going to change my airway. I don't have to hyperextend the airway or anything else. This is just designed to follow the natural curvature of the mouth. So it's actually easier to do if you're trying to maintain spinal precautions on a patient. But we want to have our first attempt be our best attempt, suctioned out, optimize everything you can do to get that airway on your first attempt, because every attempt after that has a lower chance of success.